Okay, this is Renal Disease and Nursing Application, Module 1 on the Student Nurse Exchange. This is going to go over a lot of core concept of renal disease. It doesn't get into the advanced critical care concepts yet, but we'll have those modules later on. This one really goes over some of the basic information and helps you apply it with concept maps at the end. Module 2 will have exam style questions that'll help you apply the information. Okay, let's start by looking at some of the basic anatomy. I know that's not the hardest part, but I think the whole module here in the Student Nurse Exchange will build on that and help you apply that information. At the end of this module, again, we'll have the concept map, so that will really help put it all together. So, kidneys, you have 2 of them. You can function with just one, but we have 2. They have major veins and arteries that feed and perfuse the kidneys. The kidneys are very dependent on adequate blood flow. That's why we worry about patients with dehydration or low blood pressure, because it can really affect kidney function and potentially kill some of the functional units in the kidneys. Nephrons are the functional unit, and we have millions of them in each kidney, in the pelvis or the main part of the kidney, and these really do a lot of the work in our kidneys. This is a glomerulus or glomerulus unit, and that's all part of the tubules. We have many tubules in each of the glomerulus complex, but you can see how those tubules, they reabsorb water, they excrete water, play a role in potassium and calcium. A lot of electrolytes are either secreted or absorbed in those tubules, so they play a big role. When we give medications to, for example, Lasix or furosemide to excrete water, we're affecting those tubules. Different medications that we give to control blood pressure are really affecting one of the chemical complexes, the angiotensin system within the kidneys, and it controls blood pressure. So all those electrolytes and things that go through those tubules and excreted and reabsorbed really play a big part in our whole body's function. The kidneys themselves, though, play a big role in our acid-base balance, and we'll talk about that in a little bit. Bicarbonate is excreted by the kidneys and helps keep our pH balance on the alkalotic side. Water removal, it works along with your antidiuretic hormone from your brain, baroreceptors, a lot of different complexes within the whole body, but your kidneys are where the water is removed. Excess water should keep your body in a good INO balance, right? So we want to make sure you're not excreting too much water, or sometimes people that have heart failure, we try to get them to excrete more water. We give them things like Lasix that affects those whole tubules, and they excrete more fluid. Erythropoiesis, so the creation of red blood cells. We think of that with the bone marrow, but actually the kidneys play a role in the creation of new red blood cells. Toxin removal, so things that are not required in the body and considered toxins by the body are excreted through the kidneys. We have to be careful, though, that they're not nephrotoxic. They could kill some of the kidneys, so we really want to know if any medications are nephrotoxic. And it plays a big role, though, in those loops, again, to get rid of things that our body doesn't need. And blood pressure control. We'll have a whole slide on this within this module. The angiotensin system really plays a role on our controlling blood pressure in our body. And again, some of our blood pressure medications affect this system, and that's how they help people with hypertension to control their blood pressure. And vitamin D activation. Vitamin D, when we take it orally, not a lot of it makes it through the body. We get a lot of it through the sun. The reaction that I'm going to show you really within the kidney helps to activate that vitamin D. Vitamin D is actually a hormone that does a lot in our body, and we know that there's a big public message out there to make sure we know what our vitamin D levels are. But you need good kidney function to really activate that vitamin D. Okay, so our kidney's role in the activation of vitamin D. We know we can get some vitamin D from vitamins and foods, but really the best amount of vitamin D, D3, is activated by sunlight in our skin, and really we need calcitrol, which is produced by the kidneys, to make this vitamin D active. And then vitamin D plays a role to really regulate our calcium and phosphorus in our body, and that's needed to really have healthy bone, have bones grow when we're little, and maintain bones being strong in old age and prevent osteoporosis. So the kidneys, through the calcitrol that makes the inactive vitamin D active, plays a role in our healthy bone formation and maintaining strong and healthy bones. Okay, now let's look at this renin-angiotensin system that the kidneys play a major role in with their release of renin, and it really helps to increase blood pressure or decrease blood pressure when it stops producing renin. So it really plays a big role, and when we look at different medications, they block some of this renin-angiotensin system to help people with hypertension. So let's look at the pathway. So you have the kidneys, and when you have low blood pressure, the kidneys produce or release renin. Renin reacts with angiotensin, which is in your bloodstream. It lives in your bloodstream. When the renin and angiotensin come into contact, they make angiotensin 1. Angiotensin 1 circulates to the lungs. The lungs convert angiotensin 1 with the ACE, or the angiotensin converting enzyme, from the lungs makes angiotensin 2. Angiotensin 2 causes vasoconstriction, and if you have vasoconstriction, you increase your blood pressure. Now, along with this, the adrenal glands that sit on top of the kidneys, they help with all of this blood pressure control by producing aldosterone when needed when we have low blood pressure. Aldosterone will also help the kidneys to reabsorb water and sodium. This is another mechanism besides the vasoconstriction that increases blood pressure when we're in danger and not perfusing our organs. So how does this happen again? The kidneys detect the low blood pressure. Remember, I said they're very sensitive to blood flow. They release renin. Renin reacts with angiotensin that's in our bloodstream. When they combine, they make angiotensin 1, goes to the lungs, and the angiotensin converting enzyme converts angiotensin 1 into 2. Once that's in our bloodstream, we have vasoconstriction. At the same time, we have aldosterone released from the adrenal glands that causes the kidneys to reabsorb water and sodium, and that also will increase blood pressure. But the whole system works in a loop. So once the blood pressure is increased enough that you're having adequate perfusion and your water and sodium have reabsorbed and play a role in increasing blood pressure, the renin stops being released from your kidneys. And when you look at different medications, they affect really the ACE. So you stop the conversion of angiotensin 1 into angiotensin 2. That causes vasodilation, so it helps decrease blood pressure. We also have medications that block aldosterone, so you don't reabsorb water and sodium, and those also help to lower blood pressure. So this is a system to help that normally exists in our body to make sure that our organs and tissues are perfused. It kicks off when we have low blood pressure and turns off when our blood pressure is adequate to perfuse. So this is all going on a constant basis as needed. People have things that are broken in this system, and we also manipulate the system with medication to help people with hypertension. Okay, some other really important things that the kidneys produce and control. Number one, bicarbonate helps control our pH. Bicarbonate is an alkalonic chemical or element, so it helps control our pH. If our blood becomes too acidotic, our kidneys will produce more bicarbonate to make our pH go more towards the alkalonic side, and we have to try to live in that normal pH range of 7.35 and 7.45. So it plays a role to keep a normal pH. We'll go over more of this in the arterial blood gas module that really helps understand how the respiratory system and the kidneys play a role in blood gases and pH in our body. The next thing is potassium. It helps secrete and reabsorb potassium. And we all know this in all our nursing questions. When you have too high of potassium or too low of potassium, the one big thing we worry about is cardiac rhythms. So either high or low potassium levels in the body can cause your heart to have abnormal rhythms. So we know we have to really try to keep an eye out for that with kidney problems or some of our medications. When we give Lasix, the loops of Henle in your kidneys dilate and you urinate more water, and potassium goes with it because it is not a potassium sparing diuretic. So that's why our patients are getting extra potassium supplements along with their Lasix. So potassium plays a big important role with our heart rhythms. Normal range is usually 3.5 to 5. Always go by what your book says if it's a little bit different, but it should be in that range. So anything over 5 or under 3.5, we really worry about that we're going to have problems with cardiac rhythms. BUN and creatinine, these are really waste products between what we eat and what we need to excrete. They come out in the urine and stool, but really the kidneys play the biggest role on excretion of blood urea nitrogen and creatinine. With kidney failure, these levels start to go up. We look at ratios of BUN to creatinine, so they're really important elements in our blood chemistries to look at when patients are starting to have problems with their kidneys. They start to go up, and we want to make sure that we keep an eye on them and get a range and a baseline where they start with, so we know when they're going up out of their norm. The other thing, erythropoietin is also produced by the kidneys, and I remember I talked about red blood cells. So when our red blood cell production is low, we don't have we have a low red blood cell count. When we look on our labs, we see they have a low count. Erythropoietin is produced by the kidneys, and it causes the bone marrow to make and produce more red blood cells, so it should go up in our bloodstream. When you think about if you ever have patients that you go to dialysis, you can see on their list of meds that they get erythropoietin sub-Q, and this helps them to replace what their kidneys can't do with erythropoietin. Also, patients on different chemotherapies, if it affects their bone marrow and production of red blood cells, we may add erythropoietin subcutaneously to help that bone marrow because the kidneys aren't able to keep up with that. But normally, erythropoietin is produced by our kidneys and really keeps our red blood cells in a normal range. Okay, so what can go wrong? What do we see in our patients that affect kidney function? And as we know, we can't live without our kidneys. Patients are on hemodialysis because they have chronic kidney disease or they're waiting for transplant, so we need our kidneys. Like I said, you can function with just one, but a lot of our patients are at risk for kidney damage. Aging itself is going to affect medication processing. They're more prone to nephrotoxic drugs. They can't eliminate medications as easy, so they are more at risk for damaging their kidneys from nephrotoxic chemicals or medications we give them. We really have to look at that. Their glomerular filtration rate is going to be lower, so they can't clear things out as much. Remember, GFR, glomerular filtration rate, it's a calculation. It should be above 90 mLs per hour, and that is really, we measure it when we do a creatinine clearance test and we collect their urine for 24 hours and we have the jug in ice, and creatinine is cleared by our body at a steady rate, and they'll use that to look at glomerular filtration rate. It's really an indicator of how healthy the kidneys are. Heart failure can affect perfusion of your kidneys, so patients are really at risk for kidney damage and acute kidney failure or chronic kidney failure becoming chronic because of heart failure. You're not perfusing, blood's not coming out of the heart, so it's not getting to your kidneys. I talked about medication toxicities, and we really have to be aware of that when we're looking up our meds before clinical and going through the list. One of the things your instructors want to know is that medication toxic to the kidneys, and you have to be aware of that and how you would detect that and what the safe range is for the patient. Infection infections are really with Foley catheters, and different older people are really susceptible, the elderly, to kidney infections, UTIs. They become sepsis, and that can really affect their kidney function. And kidney disease in general. There's a lot of different kidney disease out there, things with multicystic, polycystic kidneys that somebody can be born with, and also different reasons for kidney failure. And when you think about it, then they can't control blood pressure, they can't produce red blood cells, they can't convert vitamin D into active vitamin D, and have problems with calcium and phosphorus, excretion of toxins. So all of these things play a role. Perfusion of our kidneys is really regulated by how hydrated we are and our blood pressure. So we want to make sure that we have adequate blood pressures for our patient and blood volumes and hydration, so that we know their kidneys stay hydrated. They get nephron damage when they're not perfused correctly, and you really run into a lot of problems. So your water balance, they can't excrete fluids, so they're going to have water buildup. This just adds to other problems in their body, especially with heart failure. Decreased red blood cell production, so we're not going to be able to carry iron and oxygen to our cells, so they're going to be fatigued, become ischemic, causes a lot of problems. Hypertension, hypotension, because of that whole angiotensin renin system is faulty. pH balance, they become more acidic, and that is also dangerous, being more alkalotic or more acidic. But the kidneys that are damaged can't produce bicarbonate, so they can't keep that pH in a normal, balanced way. Bones can weaken, fractures, osteoporosis, things like that. So all of these things can go wrong, and we really have to watch in our patient and be aware of certain risk factors that they have. Okay, let's look at, we're going to spend most of our time on acute kidney failure, but there's acute kidney or renal failure and chronic. Acute can be reversed if caught in time and with proper treatment, and hopefully resume and recover and have normal kidney function again. Chronic kidney failure cannot be reversed, and that's a picture of a hemodialysis machine. There's different types of dialysis, but that's non-reversible, and I think that's one of the first main things to understand. So acute kidney failure has different causes and different stages. The causes of acute renal failure are classified really by where the insult is coming from. That's where I think of it. There's pre-renal, intrarenal, and post-renal. And I think this image really kind of shows it as far as location and as a cause. So different insults, think of it that way. So a pre-renal cause is a sudden or severe drop in blood pressure. Say they are rarely sick with sepsis, they're showing shock, very dehydrated. Patient that's had a flu, an elderly patient that's had the flu for 3 days and been vomiting and not drinking anything. That is before the kidneys. So it's pre-renal, it's a pre-renal cause, hypotension. And because of the lack of perfusion to the kidneys, they start to go into the phases of acute renal failure that I'll go into. So that's one of the causes. Intrarenal is inside the kidney, right? That's the location of the insult. There's some kind of damage to the kidney, toxin, drugs, like we talk about the nephrotoxic drugs. It would be an intrarenal cause of acute renal failure. Inflammation, infection, pyelonephritis, glomerulonephritis can all be an intrarenal cause of acute renal failure. Third one, post-renal failure. So it's the location of the causes, I think of it as after the kidneys. So it's a sudden obstruction of urine flow. So say we have a stone get stuck in the ureter, and the urine flow won't come down to the bladder. That would be, and it's going to damage the kidney because of the buildup of fluid. Tumors, injuries, that's one thing you worry about with certain sports. If they get a kidney injury, or trauma, car accident, something like that, it can actually damage something below the kidneys that is a post-renal cause for renal failure. Also, it talks about enlarged prostate. That would be another key thing that sits below the bladder, right? And if it gets larger, the urine's going to build up in the bladder. It can reflux up into those kidneys and cause damage. So those are the causes of acute renal failure. It's really termed by the location of where that insult comes from, pre, intra, or post-renal causes. Now there's phases of acute renal failure that we need to recognize as nurses and know when the patient is going into these phases. The first one is commonly called the initiating phase. We may miss this one. They have a low blood pressure. It only takes about 20 minutes. It can cause something called acute tubular necrosis. You've heard of that, ATN. And because of this lack of perfusion, they start to go into renal failure. In the first phase, maybe there's a little less urine flow, not really a lot going on that we would pick up on, but the disease process or failure has started. Oliguric, this is when you really see a decrease in urine output. It can go down to almost no urine output. And when you have that happen, you get fluid overload in the body, which is going to exacerbate, put pressure on the heart and the lungs. Also, you worry about all the electrolytes, the increasing potassium, problems with calcium and phosphorus regulation, and it can cause a big problem. And this is usually where we see it and pick up on it, because we start to see things in labs and the dramatic urine output decrease. This usually lasts, I think they usually say about 5 to 15 days. Use whatever they have in your book. They'll have a chart in your book. But knowing the oliguric is really where we pick up on it, and that's where we really usually start to act. We want to know people are at risk and always be aware that they're at risk. But it's this oliguric phase, the second phase, where we usually pick up on it because of the decreased urine output. Patients should have 30 mLs of urine an hour. So anything below that is decreased urine output. When we look at characteristics of urine, when it starts to go from the straw yellow, clear color to becoming darker, more concentrated urine, we worry that they're going into renal failure. Certain medications can make urine look darker, so you have to be aware of the whole picture and what's going on with the patient. Next phase is the diuretic phase. This is when the loops start to kick in and you start urinating all this extra urine that your body has held on to during the oliguric phase, but the loops really aren't functioning well. So you still don't get control of all the metabolic processes, the potassium, calcium, phosphorus at this phase. You're losing fluid, but you have to make sure at this phase they don't get dehydrated, right? Because they really aren't able to control the fluid that it's excreting and keep a good balance. Recovery phase is at the end. This is when they've made it through acute renal failure and their nephrons start to recover, and it can take up to a year for this whole process to be recovered. So we really try to get this knowing what their risk factors are, if they're elderly, if they've been sick, if they're dehydrated, what medications they've been on, have they had episodes of low blood pressure. Only takes 20 minutes of a low blood pressure to start killing off those nephrons and put somebody in acute renal failure. So this slide, I'm not going to go into chronic that much, but acute I think is a little bit more complicated. You have your causes: pre-renal, before your kidneys; intrarenal, within your kidneys; post-renal, after the kidneys. They're all causes. And then you have 4 phases: initiating, oliguric, diuretic, and recovery. And they all have really classic characteristics in those phases. Okay, so let's look at a concept map for our patient. We have some initial data there, some labs, a little synopsis of what's going on, and medical history. This will all help build our concept map or care plan if that's what you do. But we can take that data and really, even the night before, once you've got your assignment and you know that they have renal problems, you can start to build it. So the next day when you come in, you really have it started and looking great for that nursing instructor. So we have an 86-year-old patient admitted following the flu. Doesn't say how many days, but they have nausea and vomiting and they've had little PO intake. They're emitting data. They have low blood pressure, right, because they're dehydrated. The heart rate's elevated up at 90. It's trying to compensate for that low blood pressure. It's trying to perfuse their body. Respiratory rate's a little high, maybe trying to balance the pH in the blood. BUN and creatinine are just slightly elevated. Normal BUN is 7 to 20, so it's up to 21. And creatinine is usually about 0.6 to 1.1. So that is starting to affect their kidneys. I'd like to know a baseline. Is that where they normally live at? It's not that high, but I know it's elevated. So I'm worried about their renal function. It's something I'm going to watch. Urine output 100 mLs in 8 hours. I told you the rule of thumb is 30 mLs an hour. So if they had normal urine output of 30 mLs an hour, that should be up at 240 for 8 hours. So that is low. How do I assess that? Their urine also starts to get more concentrated, darker yellow, less clear. So things like that also give me an indication, even if they don't have a Foley and I can measure mLs every hour, that they're having problems with their renal function. Medical history, diabetes type 2. So we know they're not insulin dependent, but not eating and having the dehydration could potentially raise their glucose levels. They're not under control. And when you have higher glucose levels, you pull water into the vascular volume and you can have more add to the dehydration. They have heart failure, so we know that they don't perfuse their organs optimally anyway. And they have hypertension, which causes problem to the vessels and can hurt your kidneys long term. So they already have some vulnerabilities, and then you added on this flu, and that's going to be a problem for this patient. So just starting the concept map, we put the information for the patient, the pertinent information in the center. They're elderly, and they've had the flu, they're nauseated, vomiting, and little PO intake. So that right away gives us some nursing diagnosis we can put down and start with. We know that they don't have good urine output, so impaired urinary elimination. It's only 100 mLs per hour. Ineffective tissue perfusion. That blood pressure is too low, right? They're not going to be able to perfuse their tissues and their skin. So we're going to watch for things because of that inadequate tissue perfusion. And really, when you add on the nutrition, that's going to affect their skin too. So we really know that their tissues in their body and their skin are not going to be perfused. They're at risk for, we don't have a glucose level yet, but they're at risk for unstable glucose levels. And they're at risk for electrolyte imbalances. We don't have that information yet either, but we anticipate it. So we can use those risk for nursing diagnosis for things that we're going to watch for, and we know that they're potential going to develop problems with. So ineffective tissue perfusion is going to add, like I said, not only organs aren't perfused, but your skin's not perfused. So this patient is at risk for, we don't have a skin assessment. They may have great skin, but we know they're at risk for impaired skin integrity. So I'm going to have to really be overzealous to check their skin, to turn, reposition, make sure they're not having any skin breakdown. They're also, we said, nauseated, right? And until we get that nausea under control, it doesn't say we did. So they're going to be at risk for imbalanced nutrition, less than body requirements. So they're not eating. It's nothing that they're at risk for. We already know that they haven't been eating for a number of days. So they've had less than body requirements. And if the nausea is not stopped, it's just going to get worse. The urinary elimination, impaired urinary elimination is going to put that patient more at risk for those electrolyte imbalances. We're going to have to watch for really, especially the potassium balance, because they're elderly. They have heart failure, they have hypertension, they're really at risk for those abnormal heart rhythms that can be lethal for the patient because of the potassium levels. They're going to be at risk for calcium and phosphorus imbalances also, but we really are looking for those electrolytes in this patient. They're elderly and they already have cardiac decompensation. So the one nursing diagnosis of the urinary elimination really puts us to identify the risk for electrolyte imbalance. Because they can't urinate, they're building up fluids, right? Their urine output is 100. We know their BUN and creatinine are up. They're not perfusing their kidneys. They're holding on fluid. They have excess fluid volume. And so we can add that nursing diagnosis, really just building on the information we have and the other diagnosis we have and risk for diagnosis, we can add that excess fluid volume. So what are we going to do? We're going to have a really careful and strict I&O to watch what their fluids in and out. Risk for electrolyte imbalance. I'm going to make sure that the doctors ordered the labs and look and see what their potassium is, importantly. Also look at things like calcium and vitamin D, but most importantly right now I'm worried about that potassium with that patient. Impaired urinary elimination, again strict I&O. Try to get IV fluids started. That'll be in the list of orders that the doctor will give you. So we hope to that will increase pretty quickly. If they haven't gone into renal failure, they should start to urinate more, and I'm going to watch that I&O carefully. I already talked about risk for impaired skin integrity. Those things we want to do a good assessment. We want to turn and reposition, and also when they're not nauseated, really starting to introduce the nutrition again so they have good protein stores that really helps their skin integrity. Ineffective tissue perfusion. So if we can get that blood pressure back up and really stop it progressing into acute kidney failure, then with IV fluids and being able to drink things, we should be able to see that blood pressure go back up and the heart rate neutralize. The nausea, hopefully that'll go away with the flu, but we can give different medications as long as they're not nephrotoxic. Ondansetron, which is Zofran, is often given in the hospital, and that could actually affect the heart rhythm in patients, especially the elderly. So we have to be really careful of what we do to stop nausea. Hopefully this whole viral illness that they have goes away and they are able to start eating slowly, and we get that nutrition back up to par. Risk for unstable glucose. They're not eating. Their glucose levels are and they're probably not taking their medications at home. So some of the orders I would also anticipate with the IV fluids, there probably is going to be some glucose in those IV fluids. Eventually, once they hydrate them, they'll add some glucose, so D5, into those IV fluids, and as they start eating, we should get a more stable glucose. But I want to make sure I have orders that are going to let me monitor their glucose levels with an AccuCheck or whatever you use for point of care testing in your facility. Risk for electrolyte imbalance. Again, I said we're going to watch to make sure we have the orders and also make sure that they're not at risk for electrolyte imbalances causing heart dysregularity. And we're going to have to make sure those levels are normal. We may even put them on bedside EKG monitoring. So interventions, some examples. Make sure we get a weight every day. Remember, 2-pound weight gain means that their really congestive heart failure is getting worse. And when somebody's in renal failure, they're even more prone to having a weight gain, so we want to watch that. Vital signs should be at least every 4 hours. This patient may be in a step-down situation anyway, and you can always do vital signs more often. It's just really a rule for certain levels of care on floors. Usually you can't do them anymore or be required to do them maybe more than every 4 hours on a regular floor. We're going to monitor that I&O every shift, and it's going to be really strict I&O. Monitor their labs. We want to watch specifically the potassium. Skin assessment at least every shift. And then things also you could add, getting the patient up if they can tolerate it and their blood pressure doesn't go down. You can add to this concept map by what you could delegate. So you could, in your interventions, put down, I want to delegate the NA to weigh the patient every morning. I'm going to have them assist me to turn and reposition the patient. They can't assess, but you could delegate them to help you with that. Some expected outcomes you could add to this whole concept map. So you would want to see return of their blood pressure to normal range within 24 hours, within 12 hours. I know with students it's hard to put down the time frame that you expect something to resolve, but if it's something that's really emergent like blood pressure and you're starting IV fluids, really the sooner than later. If we're getting IV fluids going and medication started, really that blood pressure within 12 hours, it should be back to a normal range. We can expect the BUN and creatinine to decrease to normal range if they haven't gone in renal failure within 24 to 48 hours. I want that urine output to get back to 30 mLs per hour within 24 hours. And we know that would mean normal renal function. So those are all, when you look at a care map, you identify the problem, and then your assessments come off of that, and that's what builds your nursing diagnosis, right? We can put those down and what they're related to. If they're not a risk for diagnosis, if it's a regular nursing diagnosis, it's related to something. So the excessive fluid volume is related to the poor urine output. Impaired urinary elimination related to 100 mLs in 8 hours of urine output. Risk for impaired skin integrity, usually you don't put a related to for that, but we know it stemmed from ineffective tissue perfusion, and that was related to our low blood pressure. So I hope that helps kind of put all the information together when you're looking at a patient with potential acute renal failure and helps you build a map.
To gain access to other modules in this course and many other courses, as well as practice guides, textbook recommendations, and a direct line of communication to us to help with any further questions, please visit studentnurseexchange.teachable.com. Check us out on Twitter at StudentNurseEX for daily tips, tricks, and information on how to survive and pass nursing school.